Actually, for the fellows in the group, Peggy has talked about how I've moved. What you could say is I do a lot of random things, and sometimes I do. When I was a fellow, I inherited the practice of a rheumatologist in Vermont who had used a lot of glucocorticoids. He was a rheumatologist named John Bland, who was a wonderful physician. John could get people to exercise, to do anything. He saw a lot of people who were enjoyed sports and were athletes. But as I inherited John's practice, all those people who had been on glucocorticoids forever were all fracturing. And at the same time, and a lot of things that you do in life is sort of luck or being in the right place, another rheumatologist who was on the practice in Vermont, Ed Lieb, joined and brought our first bone density machine. So Ed and I were sitting in a conference room, sort of talking about all these patients having fractures. And it was a very interesting time because there was a group of rheumatologists who used a lot of glucocorticoids. And then there was sort of a sea change where we had a group of younger rheumatologists who really avoided using them at all. And so that's how I sort of first got interested in it. And I'm going to walk you through a little bit of my interest in calcium and vitamin D and how I got involved in the guidelines. You don't have to tell a group of rheumatologists that there's a lot of toxicity from glucocorticoids. I think, as I think back through my career and how I took care of patients, it was probably one of the things I sort of was concerned about the most is all the side effects I saw from all the patients I treated from the glucocorticoids that we used. I don't know if there are pediatricians in the room, but I'm trained as a pediatrician. And in pediatric lupus, where we use a lot of glucocorticoids, half the damage that those kids have coming out of childhood to adult is from the glucocorticoids they use. And much of that damage is bone health and growth. But I think one of the things that helped me focus was an article that Ken Sog wrote. So you're going to see Ken's name in a lot of these slides. And Ken was at Iowa and was looking at a group of patients with rheumatoid arthritis and was looking at all the toxicities that they got from the rheumatoid arthritis. And Ken wrote an article, I think in 1994, saying the most common serious adverse event related to glucocorticoid use is fracture. And when I am rounding with the general medicine residents who are doing rheumatology, I feel like one of my obligations is to teach them all the bad things that glucocorticoids can do. So we do that in the hallway. And we divide them into two groups, things that are unavoidable, except by stopping glucocorticoids like skin thinning and cataracts, and things that you can treat like diabetes or insomnia. And I think the good message, or the message that we know and have known for a while, is that the most common serious adverse event is fractures. And fractures are preventable, but we also know we don't do a very good job at it. So the American College of Rheumatology has sort of taken over. This is the guidelines project I was involved with, but there have been other iterations of this. And so I'm just going to walk you through that. I have no disclosure. The one disclosure I always give is that I'm not an endocrinologist. I just pretend I am sometimes. And I thought we might start by focusing our thoughts around three cases. And I think these are sort of three common people that we see in the clinical setting, and that we come back to these cases when we're done with the talk. And the first case is the common person that we see who's diagnosed with polymyalgia rheumatica. This may be the most important group we identify because by their age, and they're usually female, they're one of the groups that's at highest risk. And this is a woman, I didn't put race in, and all you know, you got to calculate race, but this is a woman who's been diagnosed with polymyalgia, but is otherwise healthy. And the question is, given her DEXA scores at hip and spine, what would you advise besides good calcium and vitamin D intake? The second woman is a woman, I think, kind of patient that we also see gets a lot of steroid toxicity. This is a 52-year-old woman. She's diagnosed with GPA, and she's going to initiate treatment with prednisone at 60 milligrams per day. Perhaps even she's received pulse Medrol. And you're expecting, unless your rituximab or whatever you use works really well, that she's going to receive a significant cumulative dose of steroids over the next year to 2 years. And the third patient is one that I think we all take care of as well, that we all worry about and I don't think I know the answer to. And this is a 32-year-old woman who has lupus, and she has bad lupus. She is the kind of person it's hard to get off glucocorticoids. And on top of that, As almost all lupus patients, life is complicated for her, and adherence is an issue. And so every time she fails with adherence with her lupus medicines, she has to get another pulse dose of glucocorticoids. And I want to show you some data that tells us about what happens when we repeatedly pulse people. So today, I want to review just a few articles on the natural history of glucocorticoid osteoporosis, because I think it will help you think about individual patients, their risk factors, depending on how long we're going to treat them. I'm going to very briefly review some ways that the treatments to prevent bone loss. I'm going to walk you through the guideline process. I know Susan did a guideline process. I'm going to give you the edited version without all the drama and the pain, but there was still some drama and pain. I'm going to review the guidelines and then just talk a little bit about what we learned going through that process. So background. About 1% of the population is treated with glucocorticoids. If you look at the recent Canadian study, I think it was 2013, 12,000 people studied. It's about 1% of people in Canada are on glucocorticoids, and it goes up to 3% after the age of 50, which is sort of a bad occurrence, both age and increasing use. We think that some studies have shown that probably 15% of vertebral fractures are at least partly contributed to by glucocorticoid exposure, and about 7.6% of non-vertebral fractures. We know that bone loss occurs early. We didn't know that when I started doing this, but we know now that it does, and I'll show you some data. And that we know that glucocorticoid use on its own doesn't tell us enough about fracture risk in an individual person, that we have to combine it with other risk factors to really understand a person's fracture risk. When I am working with the residents and initially with the fellows, I think most of us and most of them have a sense of how to manage age-related and postmenopausal osteoporosis. And in some ways, there's a lot of similarities between what happens with glucocorticoid use and what happens with aging and menopause. And I think some of the similarities are that the greatest impact is on the spine. So when women go through menopause, you see it first in the bone density of the spine, and the hip is affected later. There's also a timing issue with menopause in women where you see the greatest bone loss early with estrogen withdrawal and then a slower rate of loss. And that's very true with glucocorticoids. We know there's a fast rate of loss in the first year, and then it slows down to a chronic rate of loss. So how you think about treatment really depends on where that person is. Are they about to lose a lot of bone mass? Have they just lost a lot of bone mass? Or are they a rheumatoid patient who's on 5 milligrams who's in that period of chronic bone loss? We know both for postmenopausal osteoporosis and for glucocorticoid, DEXA is not a perfect predictor of fracture. We have to combine it with other risk factors. And there's some people who feel that bone architecture is somehow affected by glucocorticoid use in a way that makes DEXA even a poorer measure of fracture risk. So there is a group of people who feel in glucocorticoid-treated patients that we ought to be treating patients at lower thresholds than we do with non-glucocorticoid-treated patients. And then fracture risk depends on baseline bone strength, and that's true in both fields, and that other things can determine fracture risk. And one of the things people have really tried to get their head around is loss of muscle mass. So that patient you're seeing who's on chronic glucocorticoids, especially high dose, and one day you ask them to get up out of the chair and you realize they're having trouble getting up out of the chair and they're falling at home. So it isn't just the effect on bone density, but it's also the effect of glucocorticoids on their cataracts, so they don't see so well, and then they're falling, or their muscle strength. So multiple ways we can get to this. But there are also some important differences. And this may seem like a simplistic point, but I think it will really help you with your thinking, because glucocorticoid exposure is a time-limited risk factor. It potentially can go away. Aging doesn't go away, at least not yet. Maybe people here are working on making aging go away. Menopause, in theory, doesn't go away. We put people back on estrogen. But glucocorticoid use can be time-limited. The risk factor can be time-limited, and that may be important in how we think about patient care. And I'm going to show you some data about the potential for bone to recover. And that data is getting clearer and clearer. There were clues to it early on, but that data is getting stronger. The other things that I think with glucocorticoids that are different is we really have to think about the dose of the steroid, so I'll show you some data on dose. When we were going through the guidelines, we had internists, gastroenterologists, nephrologists, pulmonologists, and the internist raised her hand and said, what about asthma? What about intermittent glucocorticoid use? So I'll show you some little data that we have, but some data that's helpful. So we know continual use, again, as we said, high rates of bone loss, and then with chronic use, lower rates of bone loss. And then the obvious difference is that glucocorticoid use really impacts men, women, and children. When I remember as a fellow sitting in a conference room and being interested because of all these patients I was taking care of, and the question was, is there a safe dose of glucocorticoids I can give my patients, at least for bone health? Is there a safe dose, or generally a safe dose? I think we still debate that. So I remember looking at Journal Club at this article written in 1987 by Philip Sandbrook. They weren't using DEXA then, they were using dual photon absorptiometry. And in his articles, he sort of implied that, gee, if people were on 7 or less, their bone was probably okay. And then in 1993, an important study came out, and it was also looking at dose, and this was a study of people with rheumatoid arthritis. And it showed that women who were taking 7 milligrams of prednisone had lower spine bone density. It wasn't looking at fractures, it was looking at bone density. And so that was interesting. Okay, we began to think maybe 7 milligrams isn't safe, maybe there's a lower dose. One of the really interesting things that came out of that study, and we'll see more data on that, is at this time, that researcher did a very clever thing, which is he looked at people on steroids, people not on glucocorticoids, and people who had been but were no longer on them. And he reported that the people who had been on them but were no longer on them had the same bone density as people who had never taken them. Again, some indication about this potential for recovery. It was a clue back then. And that clue, I think we have stronger evidence. This latest study is a Canadian study I talked to you about. And in the Canadian study, they looked at past users. They looked at recent high-dose users, they looked at intermittent users, they looked at continuous users, and they found no increase in fracture risk in past or in intermittent users of glucocorticoids. A bit of a hint about the asthma question, or the inflammatory bowel disease, to tend to get these pulses. So a little bit more information. This was an article in 1993 in the Annals of Internal Medicine. This is also just a bone density study, but it was interesting, and it was interesting for 2 reasons. This was the first study, well, first of all, it was interesting because it was only 40 patients. And believe it or not, these were 40 patients with rheumatoid arthritis getting gold shots. So they were being treated for their rheumatoid arthritis with gold shots. And half of them were randomized to low dose of prednisone, 10 milligrams, for 12 weeks. And half were not given the prednisone, but they were probably given some nonsteroidal and told to tough it out. And this is what they saw, which is what everybody talked about in this study. This was looking at bone strength by on the lumbar spine using QCT, so a different technology. But they saw about an 8% loss in lumbar spine bone mass. And at that time, that was kind of shocking. More interesting, what people really didn't talk about was this. This is what happened to bone mass when they took them off the steroids. So this is real-time, acute use, a prospective study showing significant loss and the potential for significant recovery. So what about fractures? So many of you are familiar with the studies by Van Sta. These began to appear in 2000. This was a retrospective cohort study, 244,000 people treated with glucocorticoids, matched to controls, followed by for a mean of 1.3 years. Mean prednisone dose of 6.8, but huge difference in doses, very high dose, low dose, intermittent use, continual use. And 40% treated for respiratory conditions. Sometimes we forget that we think we own glucocorticoids, that we prescribe most of them, we don't. Most of them are actually being prescribed by a general internist. There are some issues with this study, which I'm not going to dwell on because the technical issues, but I'd be happy to talk about. But this was the real data that said maybe there isn't a safe dose. So they looked at fracture risk. Now we're going to talk about vertebral fractures, and I'm going to have to remind myself, some of these trials are looking at clinical fractures, and some of the drug trials that are talking about radiologic fractures, and there's a difference. And the difference, as most of you know, is that not everybody who has a radiographic fracture has symptoms or has symptoms enough to bring them into care. So we know only about 1 out of 3 radiographic fractures present as clinical. So you have to sort of do the math if you're comparing fractures from a treatment study where they're looking at x-rays versus fractures from a population study where they're searching the database for someone came in with a diagnosis of fracture. So we talked about the impact of steroids is greatest on trabecular bone, it's greatest on the spine, that hip is eventually impacted, and that's what this data showed. So if we look, there are some problems with color coordination, this should be blue, but these are people on less than 2.5 milligrams of prednisone. They saw no effect, relative risk of 1 in hip fracture risk, which is what we expect, because we know that it takes higher doses. But they saw a 50% increase in vertebral fracture risk, clinically diagnosed vertebral fractures. And then between 2.5 and 7.5 that we would consider low dose, a little bit more than a doubling of fracture risk. And then everybody over 7.5, which is a big group, some with high doses, the fracture risk got up to 5. And when we drill down these numbers, I'm going to show you even higher relative risks. But you notice hip fracture risk is going up, but less dramatically so. The other thing that Van Stoss showed, and many of you have seen this, is he looked at fracture rates in the period before glucocorticoid use. These were all non-vertebral, and then looking at vertebral fractures, spine, these are clinical vertebral. And he found a rapid increase in fracture risk within the first couple of years of using glucocorticoids, looking over a period of weeks. And then he saw a rapid decline. Again, ability for bone to recover. Not only does bone mass recover, which we sort of saw, bone density recovered, but fracture risk goes down. So something we want to weigh when we're thinking about treating patients. And then this is a painful slide, but I want to just walk you through a couple of aspects of this slide. This is his data. It was a study that came out later, about 5 years later, and it really drilled down on dose. And it drilled down on chronic use versus acute use. So if you'll just bear with me, what we're seeing here is the daily dose of the person in the study. Less than 2.5, the group I showed you in the bars, 2.5 to 4.9, 5 to 7.4, 7.5 to 15. And then this group here, very high dose users, 15 to 29 and greater than 30. And then it divides each line into cumulative dose. So cumulative dose less than 1 gram is, if you averaged it, is less than 3 milligrams a day. And cumulative dose greater than 1 gram is generally people taking 5 milligrams a day or greater. And what you can see if I scoot you over here to clinical vertebral fractures is you can see about a doubling of relative risk in clinical vertebral fractures through this spectrum. And you can see in most of these that it is the use greater, longer term use is associated with more fractures. But I want you to come down to this box, because this box actually informed how we structured the guidelines a bit. We were particularly interested in that rare patient, turns out not so rare, who's getting very high dose treatment, who's being pulsed, started on 60 milligrams a day, and for whatever reason can't get down to 5 or 10 milligrams. So they tend to stay on 15 milligrams or more. If you look at this box, this is people who are started on 30 milligrams. If you look at this box, this is cumulative dose of greater than 5 grams. So these are people taking about 14 milligrams a day. And if you look at their relative risk of vertebral fracture, it's 14. And I'll show you a little bit more data on actual fractures from a different study. You can see that as the dose goes up, especially cumulative dose, hip fracture relative risk can triple. Doesn't usually do more than triple. So that's the maximum you see in hip fracture risk. But the vertebral fracture risk really goes up astronomically once you get to very high dose use and continuous use. One of the things we struggled with is finding data about premenopausal men and women. So as we went through this process, I'll tell you more about it, the grade methodologist was a general internist. And he said, we're not going to pay any attention to bone density data in this guideline development. We are only paying attention to fractures because fractures are what patients care about. So don't tell me how much their bone density is going to down. Tell me what their absolute fracture rate is going to be. And we couldn't find it. We went through studies of women with lupus. Everything gave us relative risk. There was very little data about absolute risk. We looked at some of the alendronate trials. This happens to be Ken Sog's trial, and we looked at the line about premenopausal women and found out that looked like on placebo, not on treatment, there was about a 5% fracture risk, but we didn't know exactly what age those women were. and that risk declined with alendronate use. And then we found this study, and there's actually a series of studies like this, but this is the one I thought I would show you. And these are women at different ages who are exposed to very high doses of glucocorticoids chronically. And when you look at who they were dermatomyositis, refractory dermatomyositis, refractory lupus patients, refractory vasculitis patients. And this slide is about clinical vertebral fractures. So people who were diagnosed with a fracture when they looked retrospectively. So not surprising, older women exposed to really high dose steroids fracture. And at 10 years, this is months, more than half of them have sustained a clinical vertebral fracture. So the real vertebral fracture risk is probably much higher than that. But this is the group we looked at. So this is women who are premenopausal, but are within relevant range of menopause. And there we saw at 10 years a significant increase in clinical vertebral fractures. So about 20% of them had a clinical vertebral fracture, and if you multiply that by that factor of 3, which is a bit of a stretch, the risk is probably much higher if you look at radiographic fractures. And many of you have a lot of interest in bone know this, but it turns out radiographic fractures are actually correlated with morbidity. The clinical fractures are correlated with much higher morbidity, but radiographic fractures are as well. So now I want to stop and just go through a little bit of data on treatment. And I'm going to smush it together a little bit. We can go back and try and pull it apart. So calcium and vitamin D is a very controversial topic. It's controversial in the regular population, what the role of it, who should have it, how much should they have. Does calcium have toxicity? How much toxicity does it have? When I was just out of fellowship, we were interested in this group of patients we were taking care of. And so we had 99 patients, not very much. It was before I learned how to do sample size calculations. If I had done a sample size calculation, I would never have done this study. And we randomized people, glucocorticoid users and non-users, to calcium and vitamin D or not. And I tell you about this study for 2 reasons. One is that I was analyzing this data on my own when I was in a statistics and in my MPH class, and they had told us how to do the analysis. And this had been 3 years of work, because this is a 2-year study. And I sat on the floor in the hallway, and I did the statistical analysis. It showed no effect of calcium and vitamin D in this group of women with RA. But that day, in the statistics class, the statistics professor taught us how to look for interactions. So our theory was that steroid users might have reasons to need calcium and vitamin D because glucocorticoid use increases calcium excretion in the urine, and there's different theories about how much it affects calcium absorption in the gut. So I was at the depths of depression, 3 years of work, thinking that maybe I would go back into general internal medicine. And then I looked up how to do the interaction. I hit the interaction button. We separated the groups, and this is what we found. These were the non-glucocorticoid treated patients. These were the glucocorticoid treated patients. If they were on placebo, they lost about 3% of their bone density. Not a huge amount, because they're in that period of loss. But if they were on calcium and vitamin D, you could stabilize their bone density. Didn't increase a lot. So if you need to increase bone density, it may not be what you want to do. But I think I'm going to show you more data to suggest calcium and vitamin D may be more important than it is in the general population. Not that it's not important in that population. We didn't see an effect on the femoral neck. We did see effect on the trabecular bone in the femur, but we didn't see an effect on the femoral neck. So maybe calcium and vitamin D, a reason to think it's more important. There were a number of other trials. Ricadaci did a trial with 62 patients for 3 years, smaller number of patients, and did not find a difference. David Felsen did some meta-analyses, and finally a Cochrane review came out, and they all sort of agree. They all found there were no fracture data. There's no really good fracture data, I think, in the general population. But they did see a bone density benefit. And that was limited to the spine, not in the hip. And then we have bisphosphonates. And I think there are 27 bisphosphonate trials, so I'm not going to go through all of them with you. There was this pivotal trial by Ken Sog in 1998, looking at people on prednisone, and it was a 2-year trial, and found a fracture rate of about 5% in the placebo group. This is vertebral fractures, radiographic, and 0 in the alendronate group, and found a bone density difference. This is his data. And sometimes one of the most interesting things in data is not why the study was originally done. And one of the most interesting things in Ken's data was the calcium and vitamin D group, because I was sort of interested in calcium. So I said, well, what was happening to the people who were just getting calcium and vitamin D? And the answer was their bone density was pretty stable. Ken also divided his patients into new users and chronic users. Remember, bone loss is different in them. And he found greater loss in the new users, and that calcium and vitamin D didn't completely prevent bone loss in new users, although it seemed to in chronic users. This, I think, was reinforced by data on risedronate. So Stan Cohen's risedronate trial looked at new users. And this is what he found with calcium and vitamin D. So risedronate kept bone density stable, right? Not much of an increase. Up here, we're seeing an increase with a bisphosphonate. Here, we're not. But these are new users. These are people who are losing bone much more quickly. And look what happens with calcium vitamin D alone in a new user. In the lumbar spine, they lose a lot of bone. So there's a role for calcium vitamin D. It is always helpful to be on it. There's some situations when that's all a patient might need, but there's some situations in which they need more. And there are a few trials, not many, comparing bisphosphonates, and they show some bone differences in bone density, but no real difference in fracture risk. So I'm not going to dwell on those. And this was the Cochrane review that came out last year on bisphosphonates, 27 clinical trials that were looked at, 3,000 participants. They drilled down to 12 trials where they thought there was good evidence with over 1,000 participants. And they found a relative risk reduction of 43% in vertebral fractures, only in vertebral fractures, in people treated with bisphosphonates. And they found a number needed to treat of 31. So in glucocorticoid users, you need to treat 31 people to prevent one fracture, and that's one radiographic fracture. And this is some data on teriparatide. And remember, by this time, we weren't using calcium vitamin D as a control, so it's looking at alendronate, an 18-month trial, which showed that teriparatide seemed to have a benefit over alendronate in lumbar spine bone density. And maybe a difference in radiographic vertebral fractures, probably not a difference in clinical vertebral fractures, no difference in non-vertebral fractures, more hypercalcemia in the teriparatide patients. And this is the 18-month to 2-year data. So you can see this is radiographic fractures, about 7% in the alendronate, about 1% here in teriparatide, but no difference in non-vertebral fractures. So denosumab. The denosumab trial, the 12-month portion is completed, and it's a trial of denosumab and risedronate, but it's not published yet. We know that denosumab in postmenopausal women, sometimes it has a bone density advantage, especially in the lumbar spine, but people are not sure if that translates into a fracture benefit. This trial that has not been published is not looking at fractures as a primary outcome. It's looking at bone density. So we should know that within the next year. We'll know the results of that trial. Many of you know that there was a little bit of concern about infections with denosumab. In the initial pivotal trial, there was an increased signal of infections. And in a trial of patients who were transplant patients receiving immunosuppression, there was an increased risk of pyelonephritis and urinary tract infections in the people getting denosumab. Jeff Curtis looked at a Medicare database and looked at RA patients getting denosumab versus other bisphosphonates and did not find an increase in infection risk. But I think there is still a concern about the use of denosumab in people on multiple immunosuppressive agents or people who are somehow immunodeficient. Okay, so guidelines. I'm going to talk to you a little bit about the grade process, which I had not participated in before. So the way this began, so I've got a phone call saying, we need somebody who's not conflicted. Will you help us with this process? You don't even get to vote. You just get to help organize it. But would you help us find people who to be on the expert panel? And so the way this works is you bring together a huge group of people, and we did them across specialties. We had primary care doctors, family doctors, pediatricians, and almost all the specialties that prescribe glucocorticoids. We had endocrinologists and rheumatologists, and they formed the panel. And the panel forms the list of questions we want to look at. Now, at this point, I don't know what the process is like, and we decide we want to look broadly at people of multiple risk factors, and I'll show you how that got challenging. But first, the panel comes into the room. Now, from that group, there is going to be taken out a voting panel, and the voting panel was smaller, and they had to not be conflicted for a number of years. So that was a smaller group of people who actually, and that group's job is to take the questions posed by the expert panel and to take it through the process and vote on the answers at the end. So the expert panel gets to say, what should we look at? What groups do we care about? What's the evidence? And then the process goes from there. So let me show you that process. So first to the expert panel, which includes the voting panel. There's a core team. The core team was a general internist who had an interest in osteoporosis. I was on that group. We had a lit search specialist on that group, and we had a grade methodologist who was a general internist who didn't know much rheumatology on that group. And then we had the lit search team. And they have to form the PICO questions. I don't know if most of you are familiar with PICO questions, but you have to decide what particular populations you want to look at. What interventions do you want to look at? What drugs? So you can only do two comparators at a time. And then what's the outcome you care about? And that's when the great methodologist got up and said, we're only looking at fracture. And we all had our bone density data. And he said, throw it away. We're only looking at fractures. You select the outcomes. You decide which ones are critical. For us, fractures were the critical outcomes, not bone density. And then this group of people called the lit search team searched the literature for 6 months, compiling evidence tables, rating those tables for quality, and risk of bias, inconsistency. And then they take that evidence back to the voting panel. So now that table is smaller. It's just the voting panel. And they go through every population and every 2 comparators. And we didn't know that as we listed our questions. And then there is, we strongly recommend X, we conditionally recommend X, and we'll go through that in a little bit more detail. Develop a consensus, so sometimes the group didn't agree, and we'd have to vote or go back and vote again, and then you develop the guideline. The population of interest was kind of controversial. I'm a pediatrician. We talked to pediatricians. Pediatricians wanted to be represented, and they thought that people needed to be thinking about children, but there's very little data on absolute fracture risk in children. The transplant docs got involved and said, there's no good data in the transplant literature. Nobody wants to take that on. Most of the transplant groups follow the ACR guidelines. Would you say something about transplant? And since we were pretty naive at this point, we thought, why not? And then I think we were looking at the data on very high-dose glucocorticoid use, so we added that group in. And then, of course, women and men and age. Oh, and this is the outcome of interest was fractures. So the scope, you had to be, the group that we cared about, the literature we would do is glucocorticoid use for more than 3 months at more than 2.5 milligrams. We wanted in the guidelines to look at decision-making over time because glucocorticoids are reversible risk factors. So what happens when you stop it? And we wanted to make recommendations for how do we continue to assess people over time. We wanted to look at people who stopped treatment, people who completed treatment but still were high risk, and people who were fracturing while they were being treated. And then there was a, we talked about the woman with lupus at 32. We all looked at each other in clinic about the woman with lupus who was 32. And I think our out was, well, she could get pregnant. We don't have to think about this because she can't go on to bisphosphonate. So it's just not an issue. Just keep our fingers crossed. Hope she does well. Give her calcium. And that's as far as we go.
Is there a consensus that bone density predicts fracture?
I think there was a consensus that bone density changes are associated with fracture risk, but don't perfectly predict fracture. Yes, the group felt that that was the case. But there wasn't a consensus about how much of a relationship there was. I think that's still in question. Okay, so let's see. So I'm going to just walk you through. This is the part where I walk people through the recommendations so quickly that they don't notice it's pretty controversial. So get ready. So we could make different kinds of recommendations. We could make a strong recommendation. We had very few of those. These were we were confident that the data was there and what we were recommending, that reasonable people would want to do this. And you didn't have to have a long discussion with patients. You could say your risk is so high this is really what you may want to be doing. Conditional recommendations. A lot of our recommendations are conditional, where the desirable effects of following the recommendation probably outweigh the undesirable effects, but patients have different values about what they worry about, and so we should have a conversation. And our grade methodologist was very into, this is a decision we make with patients. Guidelines shouldn't be prescribed. Guidelines, especially conditional guidelines, should incorporate a discussion with the patient about their preferences and what they care about. So the idea is a majority of patients would do this, but they're preference sensitive. And then there's good practice recommendations, which is a fancy word we use when we really didn't have much evidence, but we thought common sense would dictate doing it. And we had a lot of those, so I'll show you those. The evidence is indirect, and it can't be graded, but we think it's probably a reasonable thing to do. So we had you couldn't really decide how to treat people till you knew what the risk was, and you couldn't know what the risk was till you did a fracture risk assessment. And that, of course, made us think about who needed to have bone density done and who didn't. And so there was a consensus that everyone, children, young people, older people, men and women, should have a sort of time-out clinical fracture risk assessment, meaning we all do this. We're in a busy day. We have somebody who's sick. We're putting them on steroids, but we're also doing X, Y, and Z, medicines to prevent infection. And we never have a time where we really sit down and drill down on fracture risk. And so what does that mean? It means thinking about not just where are the glucocorticoids today, but where do you think they're going to be over the next year? Evaluation for falls. In the exam room, you can do this just by asking people you can ask about falls and you can look at how they get up out of chairs, looking at height and weight. And we thought that evaluation should be completed pretty quickly, but that became controversial. So some patients are only seen every 3 months, and so there was a feeling that you had to give the clinician time to first treat the underlying problem, and then another 3-month visit to focus on bone. So we came up with at least within 6 months, and then should be repeated yearly. So we should go back and reassess every year. If the person is over 40 years, we thought you should use a fracture risk calculator, fracture risk assessment tool to combine their risk factors to tell you what their fracture risk was. And the committee suggested FRAX, but I'll show you another alternative. And if bone density was available, use it. And if it wasn't available, patient couldn't travel, wouldn't do it, then do the fracture risk assessment, which you can do in FRAX without bone density. So the question became, what about younger people? Should they get bone densities? When should they get bone densities? And the answer I think that we came to, which is probably conservative, is not everybody, but everybody getting very high doses should probably be monitored, especially if they have multiple risk factors. That they should probably have a baseline bone density, and then they should be monitored through that really high dose treatment if it's going to continue for at least a year. And I know all of you know FRAX. I play with FRAX a lot in my free time, and it's very interesting. When you plug in all the risk factors and you don't hit glucocorticoid use, you get a risk, right? A 10-year risk of major osteoporotic fracture, and you get a 10-year risk of hip fracture. And then, just for interest, when you're in clinic and a patient doesn't show and you have time on your hands, hit the glucocorticoid button and recalculate. When you hit, that is the strongest risk factor on that chart. You hit that button and risk goes up about 1 point, the relative risk is 1.8, almost doubles when you hit that button. It's also important when you take it out. So if somebody stops glucocorticoid, risk drops. What are the disadvantages of using FRAX? One of the disadvantages is that it only uses hip bone density. And if you have a patient who's mostly lost bone density in their spine and their spine's not looking good, but you put their hip in here and their hip's not too bad, it may underestimate their fracture risk. So that's one of the problems. The other problem is dose. So it's just, yes, they're on glucocorticoids, no. And I've just shown you a million slides that says it's important to know what dose and for how long. There was a follow-up article in 2011 where the authors, the FRAX authors said, basically they looked at the Van Stade database and they tried to drill down on fracture risk based on dose. And what they said is we have us underestimated for people who are on higher 7.5 or higher milligrams of prednisone. If your patient is on higher than 7.5 milligrams, you have to increase their risk 20% at the hip and 15% at the spine. It's hard to remember, so I just use 20%. So he says round them up 20%. Calculate the number, then round that number up if their dose is high. That probably doesn't cover for high dose use. So it gets you for a risk of someone taking maybe up to 15 milligrams. So we talked about FRAX limitations. The other risk calculator that's out there is this risk calculator. I don't know, it's 4A or 4, Foundation for Osteoporosis Research, and that allows you to put in risk factors, but it allows you to put in glucocorticoid by dose, and it allows you to add the femoral neck and the spine bone density. You can't just put in spine, you have to put in both. And you'll see, I'll show you a case in which if you use this calculator in someone with low spine bone density, their fracture risk is going to be higher than with FRAX. So it's out there. There are some questions about its use compared to FRAX. At the end of this process, we divided people who were postmenopausal into 3 groups, as usual, high, medium, and low. Remember, when you do FRAX for postmenopausal women, they either meet the threshold of 20% major osteoporotic fracture, 3% hip, or they don't. And then you decide on treatment. Or you decide on treatment by age and bone density. But here we had 3 groups. The first group is kind of obvious. In people over the age of 40, if they'd had a fracture, if anybody's had a fracture, if you're older and you've had a fracture, or you're younger, under the age of 40, and you've had a fracture, and you're continuing glucocorticoids, the recommendation is to treat. And actually the recommendation for children, which I'll get to, is the same. If they do not already meet NOF criteria for treatment, then plug them into the FRAX model, and they are high risk if by the NOF criteria they are high risk, greater than 20% major osteoporotic fracture, greater than 3. But we added this group, which is moderate risk. And the reason I want you to look at the moderate risk group is because we're suggesting you treat them. And the moderate risk group is major osteoporotic fracture between 10 and 19%, and a hip fracture risk between 1 and 3. Now, this is a conditional recommendation, not a strong recommendation, but something to think about. What about people under the age of 40? A moderate risk factor group was created by the panel based on very little data. But what they thought was common sense, that if you're treating a woman under 40 with a very low Z-score, and we were conservative here, some people thought we should have put the bar in a different place, or somebody who's having very rapid bone loss, 10% in a year, and they are continuing their glucocorticoid treatment. Those people, not a strong recommendation, but those people are at moderate risk, and you should have a conversation with them. And then low fracture risk, not. So, treatment recommendations. Optimize calcium and vitamin D for everybody, including children. Treat men and women not of childbearing potential who are at moderate to high risk of fracture. And our recommendation was to start with bisphosphonates because of cost and safety. And then we listed, the grade methodologist made us make a list. We said, no, after that, think about the patient. No, there are people out there who aren't going to be able to make those decisions. Make a list, put your order of preference. And this was the order of preference. It was a strong recommendation for women and men who are high risk, and it was a conditional recommendation if the risk was moderate, meaning have a conversation about it. Tell people what the risks are, both of the treatment, and think about it. These were the special populations. The organ transplant group, if they had good kidney function, our recommendation was to really consider treating them using the same adult guidelines. But be careful about metabolic bone disease if somebody's had a kidney transplant, or they haven't had a kidney transplant, but their kidney functions, their GFR is off. And we did not put denosumab on that list because we didn't know if denosumab would increase infection risk. But we knew that denosumab in a transplant trial had. Adult women of childbearing potential who are not planning to be pregnant now, but might be pregnant in the future. The data about actually teratogenic effects of fetuses has shown very little effect so far. So when the last set of guidelines, there wasn't much data. In this set of guidelines, there is more data. So it was people who had a child within a year or two, or sometimes when they were on bisphosphonates. There's a fair amount of data about those women, and it's not showing a lot of risk. So we're suggesting not treating people during pregnancy, or if they're planning to become pregnant during a period of treatment. But because someone's 32, we're saying don't write them off for treatment. Have a conversation about risks and benefits. But if you're going to treat them with something really short-acting, or as short-acting as we can, rather than the more long-acting agents. In children, treat children with calcium and vitamin D, and if they've had a fracture and they're continuing glucocorticoids, treat them with bisphosphonates. And in very high-dose glucocorticoid users, especially those over the age of 30, think about some treatment, at least during the periods the period of high-dose exposure, and that is all of these recommendations are conditional. None of them were strong because we have very little data in these populations. And then we went on, and I won't go into a lot of detail about what if they failed treatment, what if they fractured on treatment, what if at the end of treatment they were stable but their bone density wasn't adequate. And there's a list of some possibilities, but basically we dealt with that issue that Dennis Black has written about is if you have someone with severe glucocorticoid osteoporosis who's stable and doing fine and not fracturing on bisphosphonates, and you're now at year 5, do you keep going because they're still very osteoporotic, or do you give them a break? And I think his data said if someone is at very high risk, they're at higher risk if you take them off and keep going. And so we developed some data around that. Complete the bisphosphonate treatment if someone remains at moderate to high risk when they've completed their steroids. But if they complete their steroids, we know bone mass can recover, so consider taking them off their treatment. And I get these questions from patients all the time. Finally, that GCA patient, that PMR patient comes off their prednisone and they raise their hand and say, so do I still have to keep taking X, usually a bisphosphonate? And the answer is maybe not. Let's look at your bone density and see. Okay. So to quickly go through these cases, this is a 72-year-old woman. We calculate, this is her fracs. We add glucocorticoid use. We get a major osteoporotic fracture risk of 17% and a hip fracture risk of 3.2. She qualifies for treatment, right? Just by those numbers alone. We can round those numbers up, 20% because she's on higher dose use, but she already qualifies for treatment. If we plug her in to this other model, the Foray model that includes vertebral bone density, her risk goes up even more. So her major osteoporotic risk is 31%, her hip fracture risk over 10 years is 7%. So, and if you play with these numbers and say, okay, what threshold would I treat this patient when her hip fracture is down to minus 0.2 and a conditional recommendation for T-scores down to 0. The 52-year-old woman who's a smoker, who's diagnosed with GPA, is getting high-dose steroid treatment and is probably going to continue high-dose steroid treatment. We can plug that into FRAX, and we do, and we plug in her smoking. And her scores on their own initially don't qualify her for treatment. If we increase them 20% for her high-dose glucocorticoid use, we're very close. So her hip fracture risk is not quite there. But if we consider that she's in this very high-risk group, getting high doses to start and a lot of high-dose duration, I think you could make an argument, she was in our previous slide, for a conditional recommendation for treatment. And that treatment might be short-lived if she gets off the steroids, but trying to prevent that period of fast bone loss. If we think about the 32-year-old woman with nephritis and cerebritis, and look at her, actually what we care about here is her Z-score. There's no calculator to estimate her fracture risk. But you may want to follow her bone density. And if she either starts very low, or if she loses bone density very quickly, then you may want to consider putting her on treatment. Discussing the pregnancy issue with some realizing that she might recover her bone mass, but you don't know. And one of the questions we dealt with is, have we exposed people to a lot of risk if we give them a year of bisphosphonates that they didn't need? And I think rheumatologists end up giving people a lot of things sometimes they end up not needing, and the feeling was the risk of a bisphosphonate was pretty low. So I think we've gone through these things. I'll just finish up by saying there's a lot of limitations to this. This is really imperfect. And that's why I think knowing the initial data about the natural history of bone loss helps you think through the particular risk for a particular patient. Guidelines are not meant to help you with unusual patients. There was a period of public comment, and people would write in saying, what about my patient who's had 3 fractures, her estrogen level's low, the so-and-so, but her insurance company? Guidelines can't answer those questions. I think what we're trying to accomplish with guidelines is basic recommendations for general internists and specialists and rheumatologists. And anything that gets complicated should be going to a specialist in bone health, right? So I think we're just trying to get the basics. We've talked about, so the biggest limitation is the limitation of the fracture risk calculators. They're not perfect for all the reasons we've talked about here. And if somebody's been treated, they haven't been validated. The calculation of fracture risk is in an untreated population. Why does that matter? Because we know that people, once they have bisphosphonate treatment, even if their bone density doesn't increase, their fracture risk goes down. So then you've got a problem with that bone density and really reliably predicting future fracture risk. We don't have good data still for young people. Most of the studies were looking at bone density, not at fracture, although in the cumulative studies, there was pretty good fracture data for vertebral fractures. Lack of long-term data. But the strengths, I think, was the grade methodology, although it was incredibly painful. There were a lot of clinicians in that room. I think one of the things I was really pleased about is there were pulmonary doctors, gastroenterologists. Everybody was in that room together, sort of learning from each other. I think that was, we had patients in the room. We had pediatricians in the room. That was a great experience. And its emphasis on really talking to patients about how you make decisions and trying to include special populations, knowing we had limited data. The other limitation we have, we know, one of the things the guidelines wanted to do was to give people fairly simple recommendations because we know we don't assess and we don't treat. And the more complicated we made that, the less likely people were going to assess or treat. And I think that's one of the reasons where we said treat with bisphosphonates. Start with bisphosphonates unless there's a contraindication, which there are a list of, but we won't go through those today. Thank you.